very good morning to you all. I, Dr. Shalika Sharma, take privilege of anchoring this event, and it gives me a great pleasure to extend you a warm welcome on behalf of Department of Anaesthesia, Santokba Durlabhji Memorial Hospital, Jaipur, and Jaipur Society of Anaesthesiologists. We all have assembled today for symposium on recent advances in anesthesia for hepato-biliary pancreatic and gastrointestinal surgery. To begin with, I welcome respected Yogendra Durlabhji, Secretary SD Trust, and Dr. K.K. Singh Sir, Advisor to the Secretary SD Trust, Dr. Fareed Ahmed, Professor, President of JSA, Dr. Atul Purohit, Secretary JSA, and Dr. V.K. Parashar, Organizing Chairman of CME. As a customary, to honor them, I request Dr. V.K. Parashar, Organizing Chairman, to felicitate the Chief Guest. Before we further advance with our sessions for the day, I would like to request all the dignitaries to come up for lighting the lamp. To proceed further, I invite our organizing chairman, Dr. V.K. Parashar, to say a few words.
Good morning. We are really delighted that our Honorable Secretary, Sri Yogendra Durlabhji, has come and accepted our request to be an inaugural chief guest. On behalf of SDMH Hospital and SDMH Parivar and Department of Anaesthesia, I welcome you all, especially Sri Secretary Durlabhji and K.K. Singh ji, the advisor to the Secretary, Fareed Ahmed, President, Jaipur Society of Anaesthesiologists, and all senior fellows. Today's CME, as known to all of us, is for the recent advances in hepato-biliary and gastrointestinal surgery. The GI surgery or gastrointestinal surgery makes a major chunk among all sorts of surgeries, in number of surgeries and varieties of the surgeries, and even in the emergency, it comes next to the trauma surgery when you talk about the quantum of the surgeries and the type of the surgery. In our hospital, we commissioned the Department of Gastrointestinal Surgery, and a setup was established in June 2014 with the dedicated services from the doctors, all the other staff. We have 4 dedicated OTs, 8-bedded ICU, pre-operative, post-operative area. Just to a brief note, then since then, from 2014, the supramajor surgeries done in our department, Whipple's 263, although the last, if you calculate, it's more than 500. Left anterior resection 304, TLE, that is esophagus surgeries, 90, and total colectomy with pouch. As per the GI surgeons' information, that these are one of the largest series in northern India done by us. The pheochromocytoma 72, bariatric surgery 213, fundoplication 217, and left APRs. This CME was actually planned in 2021, but because of the wave of corona, we had to postpone it. So now we got the opportunity to organize this CME. And actually the purpose of organizing CME in our view is that we interact with the various center persons working and get newer techniques of anesthesia, newer methods, so that all of us become updated in the taking care of the patient. We have taken speakers from various centers of Jaipur, SMH Medical College, NIMS, Mahatma Gandhi, like that, and different topics related to gastrosurgery have been allotted, and I feel that this may be and this GI surgery is supposed to be high-risk surgery because many patients are of elderly age group with number of comorbidities. So because of that, their recovery and their anesthetic management and post-operative management needs more attention. The type of surgery, like Whipple surgery, like LAR surgery, long surgery, there is blood loss, there is electrolyte imbalances, pain management. So all these makes the surgery a high-risk surgery. And many of the patients do present already with the sepsis, and then managing anesthesia during sepsis and post-operative another challenging aspect. Upper abdominal surgery do have a lung compromise problem. So all these things make GI surgery in a sort of a challenging one. So looking forward for a very fruitful and enriching experience amongst ourselves during the day, and I hope we will ourselves updated with recent advances from the various speakers and the interaction with the delegates. I end with a small quote from the Margaret Fuller. If you have knowledge, let others light their candles in it. Thank you very much, and thank you. My humble request to Secretary to say a few words from there only.
Vinod, I'm extremely gratified to see the sort of effort you've made to garner knowledge. And this has always been the strength of SDMH, maybe small groups, maybe larger groups, but the attempt is always to take knowledge to the next frontier, and I'm really happy that this has been done in this case with anesthesia, and I'm sure you'll continue to do this in the near future. Thank you.
I now call upon Dr. K.K. Singh sir to deliver the inaugural speech.
Esteemed guests who have come here today and speakers and those participating in this CME, Shri Yogendra Durlabhji, Secretary, SD Trust, Dr. V.K. Parashar and his team of anesthetists at SDMH and all other participants, a hearty welcome on behalf of the Secretary SD Trust and SDMH. As you all know, Shri Yogendra Durlabhji has been the pivotal force for ensuring a regular CME, a regular conduction of workshops and conferences. The last 2 years, unfortunately, we have gone down because of the COVID-19. This is a humble beginning which will ensure that other departments copy the Department for Anaesthesiology for greater knowledge sharing and making CME and the workshops and conferences a regular feature at SDMH, which is always there because of one person who made sure that we conduct these academic activities at a regular pace. No words can thank the Secretary from the House of Durlabhji, who has made knowledge as a forefront for improving our clientele services to the people who come to this hospital, whether they are rich or whether they are poor. No person has ever turned back because of lack of fund. Its ethos has been to look after the people of Rajasthan and Western India with the latest technology and the latest wherewithal academically and with a sincere effort which is established as per current medical evidence. I'm glad that Dr. V.K. Parashar has made sure that this humble beginning is just a starter of other academic activities at this center. He's put in a lot of effort and his team to put together this particular CME. Those of you who have been associated with this hospital will know that academics forms a very important part of our curriculum and our training. And hence, when we induct people in the DNB program for all the subjects that we are training our people in more than 100 per year, is because our academic front is very strong. I wish all the participants the very best. I wish Dr. Parashar and his team good luck, and maybe all learn from this particular CME. And this is why what the last quote that Dr. V.K. Parashar made was on the candles and light and knowledge. Let us light more lights today in anesthesiology so that ignorance becomes lesser and lesser. And may you all enjoy this particular CME academically and otherwise. Thank you. God bless you. Jai Hind.
Thank you, sir, for your words of wisdom. Now I request Dr. Fareed Ahmed, President JSA, to say a few words.
Good morning to everyone. I welcome all dignitaries and persons to enjoy this beautiful morning sessions. After a long gap of COVID aura, now we are getting together and starting the CMEs and other activities. I hope all these activities will continue forwards. Welcome again to all of you. Thank you.
Organizer gave us 45 minutes for discussion, so we will try to finish on time. So esophagus surgery is a complex surgery. There is a requirement of the multidisciplinary approach for starting from the diagnosis, what are the perioperative management and need of ICU care. So without wasting of time, I start questioning. First question to Dr. Rajesh Bhojwani. What are the outline for diagnosis of esophagus carcinoma?
See, basically, you have a patient who, typically it's an elderly patient who's more than usually about 60 years of age, half of them would be smokers. They present with dysphagia, which is usually recent onset, 1 month, 2 months, not more. By and large, if they have a dysphagia of more than 6 months, they will eventually turn out to be unresectable or advanced disease. And there's a very clear-cut protocol for investigation. You do an endoscopy because the first symptom, if it is dysphagia, which is there in most of these patients, you do an endoscopy, you find a growth, you take a biopsy, and the biopsy will turn out positive. It will either be a squamous cell carcinoma or an adenocarcinoma. And thereafter, the further investigational protocol begins, but then the diagnosis settles there. It is not a disease wherein the diagnosis is in confusion usually, or the diagnosis is never difficult.
So when do you advise chemoradiotherapy before taking for surgery?
See, by and large, I tell you in the Indian context, every patient who has a T3 disease or has a node positive, he will undergo a neoadjuvant chemoradiation, be it squamous cell carcinoma, be it adenocarcinoma. Let's not go into the details of the protocols, but by and large, all of them will go in for a neoadjuvant chemoradiation. This is not controversial. What is controversial is, what are the patients where you do not need surgery later on, or who are clearly inoperable? But then I am not sure if that will interest the audience. So if you have a lesion in the cervical esophagus, by and large, surgery is not an option. If you have a lesion in the upper thoracic esophagus, which would mean, say, less than 20 to 23 centimeters from the incisors on endoscopy, it is not a surgical candidate, because the important thing is that you would need 8 to 10 centimeters of margin on the esophagus. Because esophageal carcinoma, traverses submucosally. So even if you, with the naked eye, you don't find any disease at the cut margin, if you send it for biopsy, 1 out of 100 might have the disease positive there. So if you have the esophageal malignancy here in the upper thoracic esophagus, you won't get the 10 centimeter margin. If it is the cervical esophagus, it's out of question, because then you'll be going into the piriforms. And lower down, you can operate with various techniques that are available. But unless you have a T1 lesion or a carcinoma in situ, or a very carefully and definitively assessed T2 lesion without nodal spread, With the help of PET scan, endoscopic ultrasound, biopsy, etc., you would need a neoadjuvant chemotherapy in almost all of these patients. And I'm saying this in Indian context because in Indian context, you won't get to diagnose patients who are carcinoma in C2 or T1. In Japan, Korea, it's very common. Not in the Indian setting, I think.
So how much cycle you give for chemoradiotherapy?
No, that's also by and large variable. So it's not about the cycle. For example, the G junction adenocarcinomas, they go in for sometimes FLOT regime, which is 4 cycles only. Okay, for the squamous cell carcinoma, they give 6 cycles. Radiation, by and large, most of the radiation oncologists will give about 45 to 50.4 gray, spread over usually about 25 days, 21 days. They have their own protocols. And then they try to cover the lesion based on the imaging that they have. But what's important, maybe as an anesthetist, you might know or you might want this information that today if the patient is diagnosed and goes in for neoadjuvant chemotherapy tomorrow, it will take him at least approximately about 2.5 months to get that completed. And then you have to wait for another 4 to 6 weeks to bring him on the table. So usually it's a gap of about 3 to 3.5 months.
Thank you. So our discussion is moving through like esophageal carcinoma patient posted for esophagectomy. So my next question to Dr. Swami, what are the importance of preoperative evaluation when a patient for esophagectomy?
Like when a patient has to undergo esophagectomy, whatever technique we decide, I feel that pre-op evaluation is probably the most important part of it. Perioperative, like during surgery or post-operatively, yes, there are factors which need to be looked into, like pain and everything. But pre-op preparation is probably what will affect the outcome. And here, most of the patients that we get are elderly with multiple comorbidities and, of course, a very poor nutritional status. So we have to have a good screening in the pre-anesthesia clinic, which would revolve around assessing the physical status, the nutritional status, of course, the what all systems can be optimized, we optimize them before taking up. And then thirdly, of course, risk stratification, which not only involve the physical status, but also the stage of cancer. Neoadjuvant chemoradiotherapy, as Dr. Bhojwani just said, because that itself per se can lead to almost 15% decrease in cardiac output. Myocardial function can be affected by almost 15%. And of course, the hospital where the surgery has to be done, that also adds to the risk stratification. Because if the hospital is doing large volumes of this surgery, then the thing would be geared up and then that becomes a routine surgery for that place. So as we proceed with the assessment, our cardiac evaluation is a must where MET score is a very important thing and an ECG. Most of the times these two things would, a good MET score and a normal ECG, we don't really have to proceed with, get anything else done. But if we find abnormalities in these, then we get an echo done. But unfortunately, echo is too operator dependent. 2D echo, we really are not very sure whether what we are seeing, the report we are getting, that actually signifies the myocardial function that is still available. So then we may have to go in for a TMT or a DSE. And as I think Dr. Priyanka, was it Dr. Priyanka, I think, who said that DSE is not available at a lot of centers. But TMT can always be done. So we assess the cardiac status and see if it needs some optimization, some beta blockers need to be added or something has to be added for that. Then as far as respiratory assessment is done, to be done, a PFT is a must, as most of these cases may require one lung ventilation, although Dr. Bhojwani is doing esophagectomy with a single lumen tube since last few years, and he is happy with that. But most of the centers, one lung ventilation is what is done, and a PFT is a must. That PFT, getting a PFT done means like we have to act on it as well. Because obviously there would be some derangements and we have to work on that. We may have to ask a pulmonologist to add some bronchodilators. A chest physiotherapy would be a very important thing. And of course, as Vanna has been pointing, an incentive spirometry would, were you talking about incentives? Achha. Oh, sorry. So, incentive spirometry and chest physiotherapy are two things which would help us improve the chest status, and of course the ventilation part, post-op ventilation part gets shortened. Then of course I always keep telling my students that bedside pulmonary function tests are just as important as getting PFTs done, because PFT is not a very simple test. Each person would require to perform it at least 4 or 5 times before we can actually assess the physiological status of the lung. So the bedside tests are, I think, they collaborate with that thing. And for blood tests, a complete blood count is always desired, and renal function tests, liver function tests, blood sugar, and most importantly, albumin, as that would tell us about the nutritional status. And if it is really low, we need to ask the surgeon to wait for a few days, involve a nutritionist and ask him or her to add some proteins and fats so that some amount of muscle mass can build up, and make the patient walk a bit to tone up the muscles. This not only helps in this improvement in protein status of the body, not only improves in the anastomosis, it also helps us in weaning the patient. So this is another aspect which needs to be looked into. Many a times the nutritional part is missed out on it.
See, obviously, most of these patients present with dysphagia, and they are by and large, undernourished, because the symptoms have been there for 2 months. Now, earlier, when we were operating without the neoadjuvant chemoradiation, we would either operate straight away if the physical condition was okay, or if they were not good, we would request the endoscopist to put in a rise tube and then feed. Okay, that was the scenario before NACTRT. Now, because most of these patients will undergo NACTRT, suppose the radiation starts today, they will have some edema, dysphagia worsens for 3-4 days, 5 days. Within 7 days, the dysphagia resolves. It resolves. They start eating very well. Even with 1 cycle of chemotherapy, they start eating very well. So 90% of patients, maybe more, won't require any portal for feeding if you start them on NACTRT. Those who do not respond, you get an alarm in your mind that they may not be the proper responders. They may actually be the non-responders. So you wait for about maybe 2 cycles, maybe about 7 days. And if, say, imaging-wise, they are responding, the tumor is resolving, but the dysphagia still continues, you might have to think of this nasogastric intubation and feeding. Okay. We avoid feeding jejunostomy for the simple reason that during the operation, you need a proper gastric conduit, and you do not want that gastrostomy place to interfere with the conduit which is to be taken up into the neck and anastomosis. So the choice is, in fact, to improve the nutrition, the choice is nasogastric intubation or TP and SSL. In those patients wherein despite an NACTRT commencement, you are not able to resolve the nutrition problem.
Thank you. So I want to ask in short, just outline what are the surgical approaches for esophagectomy and which one you prefer for nowadays?
See, approaches have been many, of course. But our preference today is what was earlier known as TLE, or the thoracolaparoscopic esophagectomy. Now we call it minimal invasive esophagectomy, MIE. Now there would be centers which do the thoracic part thoracoscopically. There would be centers which do abdominal part also laparoscopically. So there are various combinations. What's important is, what has happened in the last, I would say, almost about 1.5 decades is, earlier on, many centers, and even today, many centers, still do transhital esophagectomy. Now, why was transhital esophagectomy being done and promoted? Basically was because thoracotomy had its own morbidity, and a lot of morbidity, which continued for about 1 or 2 months, particularly the pain, and the patients won't breathe post-op. Analgesia was an issue. So there was an attempt towards doing something which did not require the chest to be open. And therefore the surgeons resorted to this technique wherein they would enlarge the hiatus and dissect around the esophagus and blindly not open the chest at all. But then it had its limitation, because even if you have a wide hiatus, good retractors, some good light, despite that, you will never be confident enough to dissect the lymph nodes around. Because you have the heart there, you have the aorta there, you have the pulmonary hilum on both the sides. So by and large, this operation consisted of only taking the esophageal tube out and anastomosing the gastric conduit there. So we were not dealing with the lymph nodes. And for almost about 1 decade or maybe more, there was a controversy because the Japanese surgeons were doing it. They were doing what we called at that point of time radical esophagectomy, 3-field, 2-field, nodal dissection in the neck, nodal dissection in the mediastinum, nodal dissection in the abdomen. And they said that their results were better. The Western people did transhital. They said, no, our results are also as good. It does not add to the survival or outcome. But after the advent of laparoscopy, thoracoscopy, because now everybody was comfortable doing the mediastinal dissection also without opening the chest. So now West also started doing the lymph node dissection. And now many papers have come saying that radical dissection is better than the transhital simple esophageal resection. So this is how the techniques have resolved. But I think this is the way to go. Thoracoscopic remains the standard in the best centers of the world. Laparoscopic part is optional. If you ask me, in our setting, it is an option because we don't resort to laparoscopy in most patients. When we started, we did, because it adds a lot of cost and it adds time. So, in fact, there was a randomized trial which said that laparoscopic addition to thoracoscopy also favors the advantage in favor of minimally invasive esophagectomy, but that stands controversial. There was only one randomized controlled trial which proved that. Otherwise, if you look at it worldwide, except in US, most centers do what we call hybrid MIE, which would mean thoracoscopic and open laparotomy. So the techniques are very many actually.
So what are the sites of port site for thoracoscopy? So anesthetists can plan for pain management and for
Yeah, so it depends. Like we do it in prone position ever since we started, except probably for 1 or 2 cases earlier in the beginning, 2007, we did in lateral position. Now, after those 2 cases, we have been doing almost always prone. Now, there's another position called a semi-prone. And the advantage of semi-prone position, which is slight bit of tilt, the right chest comes slightly up, the left chest goes slightly down. And the advantage is quoted is that just in case there is a bleed which is intractable, conversion is easier, bleed control is easier. Touchwood, except for one patient, long back, 8-10 years back, wherein we had some massive spurter from the arch of aorta, we have never had to convert a patient of thoracoscopic esophagectomy for the reason of bleed. So that was long back. By and large, we have been able to manage everything with the prone position. When you have the prone position, the ports are very simple. There's one port at the angle of scapula. There's one on the medial border of scapula. There's another, I think, about 8 space. So basically, there's a triangle which is to be formed. And very rarely we'll need maybe another 5 mm port for the assistant to help in case you have some suturing, some bleed, but very rare. I don't think it's more than maybe 10% of patients.
Okay, so airway management is very important for anesthetists. So what are the advantage and disadvantage in between DLT and single lumen tube or bronchial blockers for one lung ventilation? Dr. Swami, please give your comment.
Well, as I just said, that Dr. Bhojwani has been doing it on single lumen, and there have been a number of studies, like especially in 2014, Zhang and Liu and et al. They came up, did esophagectomies, thoracoscopic esophagectomies on about 50 patients, and they published it in one of the thoracic journals. And they said that there is no difference in the ease of doing the surgery and the outcomes when they did it on that and created an artificial pneumo. But most of the centers are still doing it as a one lung ventilation. And for that, there are two modalities which are most commonly used. One, of course, is double lumen tube, which is the most widely used, and the other one is bronchial blockers. Bronchial blockers, we always had problem in putting them in the right bronchus because they were single-limbed. Now we have double-limbed bronchial blockers, and which are actually helping us isolate either of the lungs very nicely, and the placement is not difficult. But double lumen tube has a definite advantage that of ease of insertion. Both the lungs can be independently isolated, whichever one we want, and we can do a endobronchial suction on either of the lungs. But the disadvantage of double lumen tube is that first and foremost, sizing is a problem. You decide upon a size and you can never be sure whether this will actually isolate the lung or not, because whatever size you decide, that may not be long enough for that particular patient. Second, of course, is in difficult airways, it's difficult to intubate with a double lumen tube. And so much so that it may lead to laryngobronchial trauma as well. Third thing which is negative about double lumen tube is that at the end of surgery, if we need to ventilate the patient, then we have to change it to a single lumen tube, take it out and put in a single lumen. Double-limbed bronchial blockers have taken preference over double lumen tubes in the sense that it takes care of most of these things. First, its insertion is not difficult. It has two limbs which go in, and where these two limbs join, that goes and fits on the carina. So the chances of putting in deeper into the bronchus is negligible. Secondly, in difficult intubation, difficult airways, there it's obviously much easier because you just do an intubation with a single lumen tube, and through that you pass this in. Third thing is that while you are putting in a bronchial blocker, you can continue ventilating. Most of these patients would have a compromised respiratory reserve. So continuing ventilation while putting in the bronchial blockers is another advantage that it has over double lumen tube. And of course, at the end of the surgery, if you want to ventilate the patient, you just pull this out. The bronchial blockers leave the single lumen tube in, and you ventilate the patient.
Most of surgeons asking for DLT for one lung anesthesia during thoracoscopy. But you are doing with single lumen tube. How and any advantage behind this, Dr. Bhojwani?
See, from the surgical standpoint, what we need to understand is, half the surgeons, particularly from the West, they do it in the left lateral position. So the patient is lateral, one lung is retracted, the other is compressed. You will obviously need double lumen endotracheal tube. But when the patient is prone and both the lungs are functioning and you're not retracting either, you're not compressing either, ventilation does not get affected. So it all depends on what you're doing. If you're exposed to a left lateral esophagectomy, you will probably need a DLT. Now, when it comes to prone, in fact, we also started with prone because we had been reading the literature. We had many concerns. Atul sir was also there, and that was the time when we used to have these red-colored endotracheal tubes, Roche, yeah. So, and then we would be very careful about placement, right bronchus, left bronchus. At times, when the oxygenation will go down, we'll adjust and then handle that, and we'll come up. We'll take a break for 2 minutes. decompress the chest, start again. That was the initial learning curve, I think, went on for 1 or 2 years, 3 years. After all, I don't think we have used DLT for the last more than 12 years, maybe now. Initial 2, 3 years only.
It was when we had one camp, surgical camp. So one Australian surgeon came. He was the first person who started doing single human probe. After that, we took over and we had
Oh yeah. So that was 2011. 2011. So we had this, champion surgeon from Amsterdam, who came. So that was 2011. Yeah. So for the last 10, 11 years, we have been comfortable using this. And I don't think we ever convert because hypercarbia is an issue. Maybe just once. And
sometimes when there are too many of adhesions in the lung, after the chemo, there is too much of adhesions, and he is finding difficulty. That time we may have some CO2 increase. That time we ask him to stop and then ventilate and all those things. So by and large, the single element tube has never created problem, even in the smaller, maybe low weight patients also. And surgeon is also comfortable. We are also comfortable. When we were putting this double lumen tube, at least 45 minutes used to be there. That positioning, then taking it out, then repositioning. And Atul was with me, he can vouch. We had one patient who, for her, we could not put the 30 number tube. We did not have the 28 smaller size tube. So we postponed that case, and after 3 days we got a smaller tube from the company, then we put that DLT and the surgery was done. So that used to be our Herculean task. Another thing was there, fiber optic was not there very easily available in 2011, 12. Only thing there. So, but now we are very comfortable. Surgery is also comfortable, single element tube. Thank you.
So next question to Dr. V.K. Parashar. As a anesthetist, this is very important. What are the planning for pain management?
The pain is the most important thing, especially in the thoracotomy and post-thoracotomy patient. But as it is being done thoracoscopically, so only the port pain is required. Either we can give IV or regional. Most of in our centers we are giving IV. Start with fentanyl, and later on the patient, if doesn't have any contraindication, then NSAIDs also, and post-operative morphine intramuscular also. But if there are scope for the epidural also, but only thing is this that we are avoiding epidural in the thoracoscopic, because when you give high thoracic, then you have to have very careful for this thing. And then the LMWH has also to be started for that also, which has already been done, so we have to start. Another thing is that at the port side, we are infiltrating with the local VPVK or that also takes care. The more painful is the ICD side, the intercostal drain tube. So there also we have to put the post-operatively either we, no, not inside the ICD. We are just at the site of that. Fentanyl or tramadol is the perioperatively. But if open laparotomy, then I think we can put lumbar epidural also for that part, rather than going for the thoracic one. But in our practice, we have found that using this combination of NSAID, fentanyl, PCM plus morphine, patients are by and large comfortable. But some centers are using lumbar epidural and providing the blocks, intrapleural block and erector spinae. We have no experience. How much it will going to help, I have no idea about that.
Okay. Inside the OT, Dr. Swami found that during making a pneumo for thoracoscopy, there is a sudden rise of ETCO2 level like 137, 91. So what is the cause behind it?
ये फोटो कहाँ से खींची यार? ये तो सब डॉक्टर भोजवानी ने डायरेक्टली लंग में जो है CO2 डाल दिया है, which तो सीधा वो ETCO2.
This is due to Dr. Bhojwani putting the needle because of there is a bad lung condition. Lung is adherent to chest wall. So So where is needle directly inside the lungs. So during insufflation, CO2 is coming out through retrospective like bronchi, trachea, and in our sampling line to the machine. So we found this type of complication in 2 cases. There is a sudden rise in EtCO2 and there is alarming us.
But you could diagnose it, that is good.
Immediately.
अगर अपना बैठे नहीं हो तो नहीं डायग्नोस करें.
How was the curve? How was the capillaries at that time?
It's like this, no, ma'am. There is a out of line. So there is a sudden line go up.
137 वाला तो ऊपर गया.
Yeah.
तो छत तोड़ के ऊपर निकल गया.
Sudden rising. So what is protective lung ventilation, Dr. Swami?
Part of it has already been talked about. So basically protective lung protective ventilation would mean that this technique was developed in patients of ALI. But then it directly applies to our situation as well. So here what we would do is that we would keep the tidal volume to as low as possible, so that would be around 4 to 5 ml per kg. The plateau pressure shouldn't go beyond 35 centimeters of water and give a peep of 5 to 6 centimeters. This would prevent inflammatory response, improve oxygenation, and enhance the post-op extubation, weaning and extubation.
And reduce the post-operative lung complications.
Keep monitoring the peak plateau.
Yeah.
Sorry?
Peak plateau.
Keep monitoring the peak plateau.
Yeah. Peak level, it should not be more than 30.
Okay. During thoracoscopy, Dr. Bhojwani doing esophagus dissection. And during this time, if intraoperative peak pressure increase, oxygen saturation drop, and EtCO2 increase. So what is the cause of it, and how will you manage, and do you inform surgeon? Dr. Swami.
So basically it seems that the other pleura has been injured. So pneumothorax has been created on the side which is being ventilated. So these things are happening. So first and foremost, obviously I would inform Dr. Bhojwani that we are facing this sort of problem. We need to, since he already does it on 2 lungs, but if it is one lung ventilation, then we would first, of course, ask him to stop the dissection and inflate the lung which has been deflated so that the other lung can provide the ventilation. And third, of course, is we have to put in an ICD on that side.
No, I want to, Dr. Bhojwani, do you put ICD for opposite lung or not?
So finally you have disturbed me. So, no, see, important is that when we are doing the dissection, there are nodes all around, okay? Now the boundaries for our dissection, when we enter from the right chest, obviously we'll have to give an incision on the pleura to dissect around the esophagus. What we try to do is, we take all the nodes and all the structures which have to be dissected around without opening the opposite pleura. But if we are not able to, suppose something is adherent, we'll have no choice than to open the pleura. Now, I would say that I would open the pleura probably in at least about 70% of these patients. Now, obviously, whatever you call this pneumopleura is now bilateral. Some patients will stand it, some may not. There's a very simple answer to it. If you are finding a problem, put a chest tube on the other side. But if you're not finding a problem, you don't need it. And I think about maybe 40% patients would need a chest tube bilaterally, post-operatively also. It helps. Because the issue is, suppose there's a small rent in the pleura, it'll take about 48, 72 hours to heal. And if you have some collection on the right chest, which is not coming out through the chest drain, it'll keep accumulating on the other side through that small hole, which you will not realize unless you pick it up as a pleural fusion on the chest X-ray 48 hours later. So if you have created a hole, it's always better, safer, and it's simpler to put in a chest tube on the other side. So you avoid so many other problems. And most of the times you'll be able to get away with the hypercarbia and hypoxia, and you'll be able to complete the procedure.
One more question for you. During surgery, your field of working is near to heart, trachea, and major vessels. So, what sort of anesthetic assistant may be needed here?
I am not sure as to what specific measures you take, but yes, I always try to. Yes. So because if you're using a diathermy, it might give you some rhythm disturbances. And once or twice it has so happened that I would ask you to inflate the bronchus on that side, put in your tube on that side, so that if the growth is, say, adherent to the right bronchus, usually, or sometimes, I think once or twice it has so happened, particularly maybe when DLT was there, because we have had one injury to the trachea 12, 13 years back. And I came to know only because there was something red popping out, which was not blood, and it was orangish, beautiful type of red hole there. Bulb, yes. Endotracheal tube, yeah. So we repaired it thoracoscopically. We kept the tube indwelling for 2-3 days. That patient did very well, survived for more than 4 years after that, when he developed metastasis. So I think those are the issues that come to my mind. But I'm sure there are many more issues which come to your mind and that when you watch it, and maybe you keep working behind the curtain without letting us know.
Okay, I am skipping some questions and moving little fast. What are the approaches for fluid administration, and will you prefer balance salt solution, Dr. Swami?
Yes, as we already talked about it, that balanced salt solution is the thing that needs to be used. And while talking about fluid administration, like earlier the concept was that real tight, restricted fluid administration is what was practiced, thinking that we may produce pulmonary edema if we give too much, or anastomotic leak because of tissue inflammation. But then the recent studies have shown that too little is actually too less is too little. We may be producing cardiac ischemia, we may lead to renal failure. But then on the other hand, too much of fluid is not desirable as well, as it would lead to interstitial edema and other problems. So ultimately it boils down to using a goal-directed therapy. Although almost everywhere, like RAS or any other protocols, we now have been discussing goal-directed therapy, which is basically based on certain parameters which we see on the monitor, and we give fluid accordingly. Earlier, we used to take CVP as a gold standard, but of late CVP has gone out of favor, although we still use it. So ultimately, what does goal-directed therapy say is that there are the monitors like EV1000, Vigilio flow track monitor, and other such monitors which tell us about pulse pressure variation, stroke volume variation, cardiac output, SCVO2. These would guide us better for fluid therapy. But most of the times we will not have these monitors on us, and a plain simple arterial cannulation through which we can study a pulse pressure variation and balance it with urine output.
Yeah, the most important thing is the urine output.
So these two things added together would guide us what aliquots of fluid are to be given and how much response are we getting with these aliquots. Yeah. So ultimately, reading the fluid responsiveness by urine output and pulse pressure variation, and seeing that what the liquid that we have given, that is enough or not, do we have to add some more to it?
Okay. And what is the planning of extubation, Dr. Parashar?
Usually, because the thoracic part is being done, there may be some sort of a trauma or handling of the lungs. And there's a long hours of the surgery in total. So we ventilate the patient overnight, maybe next day. And next day comfortably, there is one point which was there. uh, some surgeon, say the Japanese surgeon, they advise us that before extubation you must do the bronchoscopy because you have to see the suture line and all those things. You know? So that is one thing that before extubation either you do bronchoscopy or this thing. But we in our practice we are extubating the patient the next day because if surgery starts 10, then it's at about 6 p.m. or maybe 4 p.m. by and large by the mother shifting there, it's better. Of course, we are doing warming also, doing all those things, but still there is hypothermia, still there is, and secondly, lung inflation, lung ventilation part is there. So on ventilation, overnight we extubate the patient. On table, there are some people who have done it, you know, but in our practice, maybe whatever the number of TLEs we have done, and even earlier also, we do not, on table we have not extubated.
So now patient shifted in ICU, and as a intensivist, Dr. Aarti Kabra is there. And Dr. Aarti Kabra, what are the challenges in post-operatively in these type of patients?
Right. Thank you. I thought the discussion will, because these people, I have worked in SDMH, so all my experience of was intraoperative during anesthesia and all. See, from all the discussion, one knows that the challenges is like basically the patient related and surgery related. It's a very complex and technically challenging surgical procedure. And the patient population, as sir said in the pre-op evaluation, is like age-related. They are elderlies and also have a lot of comorbidities, which are mostly smoking-related because there is a high risk. Smokers are high risk for these kind of CA esophagus. So they naturally have COPD, bronchitis, emphysematous chest, and reactive lungs and airways. So these pre-op things are there. So naturally, if one is aware of the patient population, what happens intraoperatively, so one knows what challenges will I have to face or one has to face in the post-operative period. So see, post-operatively we have system-specific, which is like pulmonary issues, cardiac issues, and one is the procedure related, which is like the surgical related challenges, their issues, those complications. And third is overall basic critical care, which one has to always look after when the patient comes to the ICU. So regarding the system related issues or challenges like pulmonary, basically pulmonary complications these are like forms around 16 to 70% of all complications post-operatively in an esophagectomy patients. And they are the 2/3 of the morbidity. And mortality is caused by pulmonary complication because they find like a vicious circle. If that complication is not resolved, then it lead to the further complication. And the main leads because of the surgically age-related, comorbidity-related, the lung changes, and the surgery-related atelectasis and all that can lead to the atelectasis formation, the secretions pooling, infection, pneumonia, consolidation, collapse of the lung, further linked to acute respiratory failure and
So
ARDS
very
and all
important,
that.
sorry for interruption,
Yes.
we are lacking some time. So what is the role of NIV and HFNC?
NIV and HFNC, see the stage, NIV and HFNC is basically bridging, either patient gets recovered or he will get intubated. And once one decide to use NIV and HFNC, one has to be watchful closely at the bedside, at what patient he is worsening, that time one should not delay the intubation and go for early intubation and ventilation. So all NIV and HFNC one is doing to avoid the early re-intubation in the patient of these esophagectomy, because naturally, and the NIV, both are, NIV has its own negative points, especially in the esophagectomy, because there is a suture line and the vascular supply and it's a very critical balance. So one NIV with the low inspiratory pressure has been recommended, but especially the patient who are OSA, has COPD, type 2 respiratory failure, in them, if they are using NIV with cautiously low inspiratory pressure, one can go, but surgeons need to be told about that, and they need to be closely watch for anastomotic leakage and all that, which is a very prominent post-operative complication, surgical complication. And regarding HFNC, see the HFNC in this COVID era, it has been extensively used, and I have personally seen that HFNC gives a lot of patient comfort. he becomes comfortable. जो humidification मिलता है ना, then that will lead to the mucus drying of the secretions, depulugging and oxygenation. Small peep is there. That excessive pressure is not there.
So HFNC is preferred to
HFNC is
NIV.
preferred. Even
Oh,
sudden pressure. And the
last
break
question.
period is not there. Na? NIV you have to break it in between. HFNC you can continue. They can eat also. They can breathe, exercise, incentive spirometer कर लो, mobilize कर लो, कुर्सी पे बिठाओ, है ना? All things we can do.
And last,
हाँ वो है, बट देन दैट शॉर्ट पीरियड वो क्लोजली मॉनिटर है, वो बस वो
yes.
Something like NIV bothers us as a surgeon, because it is pressurized. You have the anastomosis here, leads to the distension of the gastric conduit. And, we have had our share of learning curve many years now. If the patient has been optimized preoperatively well, if the patient selection is good, if the surgery has been good, if the analgesia has been good post-operatively, you won't need any of these. It is just the twin nasal cannula, and that's also only just for about 24 hours. If we are actually requiring HFNC and IV, I think we must try and see what's going wrong. There's something which is going wrong.
So thank you, and I am closing. Last question. Okay.
My question is from the anesthetists who are in the panel. Since morning we are discussing about the use of opioids for the pain management, but in these type of patients who are having malignancy, poor nutritional state, and most of the patients are having restricted mobility also, and moreover the surgery is going on the intestine, part of intestine. So how do you feel, are there any chances of SAIO, intestinal obstruction, and gastric distension? So what are the chances of these with using the opioids as a mainstay in
the
painkiller?
dosage which we are using, optimized dosage of the analgesics, and we have not found any problem with the obstruction has come or the if you give larger doses of the morphine or the narcotics, inherently, then it may be there. But because we are using PCM, or if not contraindicated, then SCR. So combination of the drugs are there. So no drug is absolutely giving in a higher dosage. Another thing, Dr. Anjum, who has been using morphine left, right, and central, and we have the morphine, if you are giving in the doses with the regular interval, and will never cause respiratory depression, or this thing. It is only in the higher doses and control, then won't be there. Because the morphine is one of the very safest drug if it is given in a proper dosage, proper interval. So that is what our experience. But in not all TLE cases, we are not using morphine. We are using NSAID or maybe fentanyl and PCM combination. But interval, different interval, and patients are usually comfortable.
Thank you all panelists for making a very informative session.